You folks hear me? Yeah, the lake is amazing. My ritual is come the night before, take a run around the lake, and then go to my favorite restaurant, the Skinny Pancake. Just down by the lake, have a beer and a crap. That's a real treat. But I don't want to age Dorothy. So Dorothy wasn't at Minnesota when I started. She came a lot longer. When I started, George Bigelow had just finished. I saw George when he came back for something in 71, and Roland Griffiths was finishing. So Roland and I got to be good friends. He was from California. He said, "Hey, it's going to be 20 below zero. Let's sleep outside. You know how to do it." And he had cowboy boots and jeans. I said, "Ditch the cowboy boots and jeans." Anyway, this for me, this is kind of a celebration and a family reunion. This program is amazing, and the topic, behavioral pharmacology, as Steve just mentioned, had just, if you flew here, your pilot might have been wearing a wrist monitor that taps into Steve Hirsch and others at Joe Brady's Institute on how to maintain your sleep tank and using behavioral economics and pharmacology principles. So hopefully your pilot was one of those. By disclosure, I'm not going to read all of this, but I consult in lots of different things. Everything I'm going to talk about, I'm also involved in consulting, whether it's psychedelic medicines development, tobacco, abuse potential. For a living, I do 8-factor analyses and abuse potential assessments for new medicines and so forth. Roland, the programs of Johns Hopkins and University of Vermont are incredibly intertwined. And for me, my personal friend and mentor and collaborator of more of a half a century, they all passed within a year. I learned a lot about death and dying with dignity, taking advantage of your last time to continue to do good things. My sister was in that same year, by the way. John Hughes, I just want to mention a couple of more or less personal things. He was a towering giant with Roland Griffiths in 1978. Within a year or two, I was talking to John Hughes about carbon monoxide assessment and basics that we needed for measuring. I mean, how do you measure smoking in the laboratory? And he was incredibly helpful. And then a few years later, I visited my old stomping ground, Deal Hall at the University of Minnesota, and that's when I met Dorothy Hatsukami, who I seemed like she was like 12 years old, and she and Roy Pickens and Steve Gust and John Hughes were doing these amazing studies on tobacco, the Hughes-Hatsukami withdrawal scale that were transformative. And he was the founder of the Society for Research on Nicotine and Tobacco. And it was an interesting time. There were discussions, should tobacco industry be allowed? And there was a big debate. And John and Pomerleau and a lot of us said, we've been criticizing them for not being transparent. Why shouldn't they be to the meetings? But they've got to disclose. So we believed in sunshine and disclosure. John was amazing. Couldn't figure out, a lot of us were surprised. He came from Mississippi, went up to Minnesota, then further north, but then helped establish this behavioral pharmacology empire here, as Steve mentioned. Warren Bickel and John and Steve came within a year of each other in the early 80s to the behavioral pharmacology program. As you heard, there was also migration with NIDA intramural program. I walked down the hallway, hired at NIDA because the secretary said to the NIDA director, find out if nicotine is addictive. So what did the director do? He turned to Steve Goldberg, behavioral pharmacologist, to do the animal work. Met Roland Griffiths in the restroom in the D building and where the director learned about that I might be able to help. So I walked down the hall as long as I could stay at Hopkins. But Warren was amazingly inspiring. And very early on, he was looking at animal data with fixed ratio schedules, including work that we had done at Minnesota, and applying demand curves. And he said, this is really cool. He showed it to me. He said, there's a demand curve. I said, what's that? And he saw that there was a lot of order that fit with economics. And that was just fascinating. And then I really got to know him closer in some ways by distance when I was heading the Robert Wood Johnson Innovators Program, and we did an innovators-based book on drug addiction treatment in the 21st century, and Warren was a co-editor. He was also CPDD president at the time. And his compassion for people with addiction and the fact that they should have treatments that work and options, not just formal treatments, but behavioral management that wasn't regarded as treatment by a lot of people at that time, and also harm reduction. And how do you migrate people? Surgeon General Koop's mantra was that we've got to make it easier to get what helps people, including harm reduction, and harder to get what kills people. And a lot of that is about behavioral economics. By the way, our group at Pinney Associates formed a nonprofit to get naloxone over the counter. And we discussed this with NIDA. We think we helped drop the opioid deaths. Why? Because when that was approved in 2023, the big companies dropped their prices in half. And that group, Harm Reduction Therapeutics, ships directly to treatment programs. So there's a lot more naloxone out there for the same amount of money. Behavioral economics is fundamental. And Warren was one of the people that basically showed how it worked and made it credible and developed the science. And you're going to hear more about that at the conference. The Hopkins and Vermont program are incredibly intertwined. And a lot of you here have been at one or the other or both, which is so cool. Or people like Eric Donnie that came from Hopkins to go to someplace else who collaborates here. I mean, it is so neat. So, and Joe Brady on his boat. How many of you were on Joe Brady's boat? He would bring the community together and give us his laws. Steve mentioned 2 of them in his meeting yesterday, because I was talking about part of your secret sauce is you're relevant. You keep changing and addressing new things. And he said, well, as Joe Brady said, man wants a blue suit, put on a blue suit. Sharon's nodding. He mentioned another one explicitly because in the debrief, people were saying, you know, resources are always tight, but yet they're fair. Well, that was law number 4, law of resource allocation. There's enough for everybody. Make sure you allocate it fairly. So he set a tone for the whole field that was benevolent, compassionate, and there were people that bridged this. And whether they're the dynamic duo or the Bobbsey twins, but Steve and Warren were intertwined, and I have dozens and dozens of pictures. I'll send Steve a catalog sometime, but they're always at meetings. I almost got run over by a bike on the bike path down by the lake when I ran ahead of them, turned around to take a picture, and they started yelling, Jack, Jack, and a bike just swerved around me. But I think the relationship is a lot like George Bigelow and actually Roland Griffiths, who went back to Minnesota together. And here's just a couple of pictures of the dynamic duo. The dynamic duo I did because about 10 years ago, 8 years ago, they both asked me to be discussants of behavioral economics presentations at SR&T. And so there they are, the dynamic duo behavioral economics. And it's fun working on this, but Maxine, George, and Roland, everybody that went through the program, a lot of people didn't even know there was a formal director. And where did behavioral pharmacology come from? Well, they were applying for a postdoc grant, and it said, what's your unit or organizational unit? So they made up the name Behavioral Pharmacology Research Unit. And when I got there in 78, people were saying, look at our cool sign. We just got this neat sign. And Steve and Warren and John, of course, named their lab the Behavioral Pharmacology Lab in 1987. All of these people are geniuses and amazing in their own right. But oftentimes, as we know, genius comes in pairs and triples and is often interconnected. It doesn't just happen. And this conference is an example of that. And this program is an example of that. Behavioral pharmacology and economics. Even though the conference title went the other way, I told Steve, well, behavioral pharmacology came first. But what makes it work? It's enabled and fueled by mentors in mentoring who are inclusive, who welcome diversity, and foster relationships and equity in the programs. And all of us that went through those programs, and anybody that knows anything about this program, knows that all of those principles apply. People like Roland saying, wow, that's really different. I hadn't thought of that idea. Let's explore it. And then being excited when findings come out that aren't what you thought. And instead of doing research to support your theory, it's like, wow, like when we were first doing tobacco and nicotine, nicotine was regarded as not addicting, and there was a lot of arguments as to why it wasn't. And we were completely open-minded about it, constantly getting surprised. But that's a secret sauce to the field. It's why the BPRU at Hopkins and the Vermont Center have just grown enormously in productivity, impact in many areas in public health and medicine. Go, Google big business organizations and behavioral economics, and you can see companies, big companies that refer to their work for industry organizational management and incentivizing their employees to have healthier lifestyles. I don't get it. Why is it so hard to sell to people for contingency management for addiction? Big companies are doing it for their own people. I'm going to highlight a few more things, aspects of behavioral pharmacology in the context of this conference and the program here. I'm going to give some examples. Steve's mentioned a couple of them. Health and medicine applications, it's all over the place. It's being assimilated. What we thought was weird and not accepted in the 70s is now just the mainstay of neuroscience, space flight, and more. So Peter Dews, in this interconnected world, he came to Harvard. He was doing some strange studies that he talks about. And then somebody said, his chair said, you got to meet this guy named B.F. Skinner, or Fred Skinner. And as Dews said, I visited the operant laboratory, and I saw that online, he didn't say online, I'll read it. He saw the ups and downs on a continuous line in real time. Who knows what he was talking about? Cumulative record. And I was at home at once and determined to follow the lead of Skinner and Heron. Well, Skinner came to Minnesota for about 7 years in the 30s, trained Ken McCorkadale, who trained Travis Thompson, who invited Skinner back to Minnesota while I was there, and I got to meet him. And I was very formal, and he said, call me Fred. Brady had him back to Hopkins later because Brady and Skinner had interconnections. And a lot of basic Skinner, a lot of basic behavioral pharmacology goes back to basics of Skinner. That time I felt more comfortable saying hello to Fred. Jim Barrett's History of Behavioral Pharmacology is really worth the read. It's just a fascinating history. A little bit more recent and really, I think a really thoughtful, more recent is by one of the people in this room, but Bob Balser, Sharon Walsh, George Bigelow, and there they bring together pioneers like Marion Fishman and Chris Johansson, Roger Kelleher, Mello and Mendelsohn, a lot of people that I met at my first CPDD in 1975, just pioneers who were taking the building blocks from basic operant conditioning kinds of studies and making them relevant to the real world. Dorothy Hatsukami and Marion Fishman teaming up in the 80s on crack cocaine when the sentencing disparities were enormously different, and saying, look, by the behavioral pharmacology, they're in the same class. You shouldn't be have 10 times worse sentencing for one than the other. Why? Based on rat, monkey, and human data. Travis Thompson, I met in 71 when Dick Meisch hired me to be his research assistant. He showed me his lab off his office where he had his Siamese fighting fish, training them, and had Bob Schuster on a call for seminars that he would have, evening seminars. It was just an amazing program for me, and I stayed on and became part of the program that Roland was just leaving in George Bigelow, the psychopharmacology training program, which, as John Grabowski pointed out to me, he said what Travis cleverly did was call it psychopharmacology because he initially was funded by NIMH, and psychopharmacology was the term of art. But John said what he actually did was bring on people that came in from behavioral programs, and he turned it into a behavioral pharmacology program. And it was amazing. So this is the laboratory I was working in. How many people, raise your hands if you actually worked in this laboratory? Sandy, Charles France, and if you know what that equipment is, raise your hand. Cumulative recorders, our sophisticated programming equipment, relays with and OR gates and counters, and you'd put wires on them. And sometimes the programs would get so complicated that they'd screw up. And I'd tell Dick Meisch, I'm going to come in at 4 in the morning because I'm going to strip all the wires off. And he said, it's got to be back together by 9 o'clock. I said, it will be. And then reprogramming. But that was the basics, we call it response cost. The basic behavioral pharmacology tools, reinforcer magnitude, schedules of reinforcement, they come together in contingency management. I mean, it's really basic, humble beginnings. So here I was learning about fixed ratio schedules, fixed interschedules, how do we vary reinforcer magnitude. For my undergraduate honors thesis, they made little dipper cups so I could vary the volume of 8% alcohol. And you see the order relationships. It's so orderly, however you're adjusting. And this is what Warren Bickel was figuring out was relevant to behavioral, what became called behavioral economics. Varying the fixed ratio size, again, cumulative recording, fixed ratio 1, 2, 4, 8. And Dick Meisch was compulsive. He would do 2, 4, 8, 16, 32, 64. And then we did all different, like concentrations of alcohol. And Bickel looked at that and said, and he's doing all the demand curve computations and seeing the orderliness of this and thinking this is really has relevance. And Maxine Sitzer with George Bigelow was already starting to say, people won't take their methadone. They won't come in. They've got dirty urines. Why don't we incentivize them with vouchers? And Warren was there and Steve was there. And that turned into contingency management. Dick Meisch is still doing this. He presented work at CPDD Iskadar 2 years ago. And this is really cool because in the lab with monkeys, he was looking at qualitatively different reinforcers. I mean, for the monkeys, cocaine beat alcohol. So what happens if you vary the reinforcement schedule and the reinforcer? It's a little more real world. Life gets more complicated. They switch more away from the less preferred reinforcer. So the basic science is still there fueling, being an engine to fuel what is relevant in the real world in health and well-being. Abuse potential, Steve mentioned, any CNS active drug has to be evaluated for abuse potential. The extent of the evaluation depends a lot on what you get in early studies. But the most important studies have emerged over time as behavioral pharmacology studies, dedicated abuse potential related studies, as FDA described it in their draft guidance in 2011 and final in 2017. So abuse potential assessment is used then to inform Controlled Assessment Act scheduling. Every drug sponsor that's working on something that affects the brain has to do at least initial steps. And depending on the drug, they might have to do a lot. They might have to do human abuse potential dedicated studies and a lot more. But these data inform the new drug application. And by disclosure, that's part of what I do. Every year, I'm doing a couple of these analyses with our team at Pinney Associates, putting it together and trying to get it right. Should the drug be scheduled? If FDA approves the drug and does not recommend scheduling, DEA can't schedule it. Not without a lot of hassle. If FDA recommends scheduling, they recommend the schedule that all of the science supports, and 9 out of 10 times, that's what DEA gives it. So these are basic fundamental behavioral pharmacology applications of every CNS active drug. So this goes into this 8-factor analysis, which also includes public health considerations, a lot of other data. But factor 1 is the big factor, and that's the basic abuse potential research. Guess what? With novel, relatively low abuse potential drugs, rodents and monkeys beat humans. They're more accurate. I loved it when FDA showed up at CPDD in 2020 with a poster basically showing that, and then but we need more analyses. And in 2022, I'll quote them on this slide. Although preclinical animal behavioral pharmacology and clinical methodology for assessing abuse liability have demonstrated high predictive validity, there is a discrepancy between post-marketing indicators of abuse and data from human abuse potential studies. Translation, the rats are smarter than humans. Or, maybe it's because they're not bothered by all these social baggage that people bring into the HAP studies. But this has led FDA to say other study approaches, e.g. behavioral economics, like money versus choice, may be worth further investigation. FDA is now funding research to have people, some of them are at Hopkins, some of them are different places, to help FDA improve their methods based on behavioral pharmacology. Because this is really important if CNS drugs get scheduled right. That's part of safety and labeling and patient safety. And as a former rat runner and monkey researcher, I was thrilled to death of FDA's conclusion. A lot of us were dealing with things like the matching law, the orderliness between response costs and reinforcer magnitude from Roger Herrnstein and others. That was being all translated into formal behavioral economics, which is still living and growing and evolving today, fueled by basic laboratory work and real-world relevance. That's part of the reason that University of Vermont's program has expanded. It is relevant and it's science-based. So the widely used progressive ratio schedules, push the reinforcer response requirement till you hit the breaking point. A lot of that came out of FDA's guidance. They wanted to simplify it and standardize it. And sponsors loved it, as I said at a FDA meeting 2 years ago, addressing the issues with this. Justin Strickland was one of the people that was presenting at that meeting because they wanted to have behavioral economics covered well. And I said, look, simplification and standardization, FDA loves it, sponsors love it, the contract research organizations love it. But a lot of times you've got to change the schedules and do things a little differently and go back to some of the more sensitive ways of doing it. And now FDA is doing just that. So who do they turn to? Well, they would turn to the dynamic duo, but Higgins is already doing this with colleagues up here. Justin Strickland, Derek Reed, Steve Hirsch at Joe Brady's Institutes for Behavioral Resources are doing it. So we'll get there. So Warren Bickel read any literature and his name just keeps popping up. He was a pioneer and he helped establish this program based on this solid science. Behavioral pharmacology studies, as you heard, they were critical in determining if nicotine was addictive. Officially, it was a habituating drug that maybe had a role in tobacco use. John Pinney was the head of the Office on Smoking and Health in the 70s, and the Secretary of Health said, Pinney, well, I heard he said, Joe Calvin, Pinney, go talk to the NIDA director. It's their job. They got to find out if it's addictive. So the NIDA director hired, as I mentioned, Goldberg to do the animal work, and a number of us. But Steve Goldberg's 1980 Science article showing robust cocaine-like self-administration was fundamental. And by 1982, it enabled the NIDA director to go to Congress and testify that we can now say that by all of the formal criteria by which we evaluate drugs for abuse potential, nicotine has abuse potential and cigarette smoking can be considered addictive. And Surgeon General Koop, who I was assigned to as his addiction guy and tobacco guy, he's learning about reinforcement schedules and getting it, how relevant this is to the nation's public health. Rats pressing levers. Who would have thought? Griffith's program was amazing. I got to be a small piece of it, but Roland wanted to just do it from, soup to nuts. Every aspect of it. We built our first smoking room, ventilated the or smoke. Maxine probably remembers this because I physically helped build it. We had smoke. We didn't know where to put it, so we had a pipe going out into the hallway. We got a lot of complaints, so my office was on the other side of the room. So I literally broke a hole in the window, and they said we'd have to get a crew. And I said, don't worry, I'll do it. I brought my toolbox in, busted open the window, ran the pipe out the window. But we were on a learning curve. Talking to John Hughes, people all over the field working together, getting ideas and doing basic things. Well, what's the pattern? What happens if you vary the reinforcement schedule? How do we vary reward? What if we have people smoke the first or the back half of the cigarette? Deprivation time, is there an orderly deprivation effect? All these fundamentals, putting it all together. With George Bigelow in another section with the bicycles, people coming up to the nurse's station, and they had a dispenser so they would eliminate human interactions and look at interbout interval, long intervals, short intervals, how many puffs you got. It was all orderly and intertwined. nicotine was still a conundrum. And Roland thought it would be really cool if you could do self-administration. I thought, yeah, that sounds kind of crazy, but can we actually do that? And Don Jasinski at NIDA said, yeah, why don't you do it? Wow, this is cool. So we did human intravenous nicotine self-administration and found out that the patterns, the curves, the interactions with behavioral pharmacology manipulations were basically the same as Steve Goldberg was finding with the monkeys. And Goldberg and I were collaborating on parallel studies. We did some of it, and then the White House shut it down. That's another story over a beer. So the 88 Surgeon General's report probably has 30 behavioral pharmacologists contributing a lot of behavioral pharmacology. And Steve called and he said, hey, why don't we do an article on the contributions of behavior analysis? I don't know why I ended up as first. I think Steve said you be first author, but he did all the work on it. But I went back and read it. Thanks, Steve. FDA commissioner, 1982, or 92, he's saying secretly, more or less, calling on a number of us to talk about nicotine. Is it really an addictive drug? Because the industry was saying no. And he's saying, well, maybe we should regulate it. But we have to demonstrate or find out if smoking is substantially driven by nicotine addiction. That was the test. You're a drug if you go to FDA and say, I've got a new drug application under development. But if you don't, and FDA says, yes, but use is basically driven by the benefits of the drug or reasons for use, FDA can say, that's a regulatable drug. So he asked about rat studies and other studies. And here I'm in the war room with the commissioner and their senior legal staff, and the legal staff are going, what's a fixed ratio study? And I'm explaining it, and they're getting the relevance that this might help them decide if the Food and Drug Administration should regulate tobacco. The backstory of a lot of that is in his book, A Question of Intent, including how our lab got shut down. But part of that was a bombshell. And the bombshell was the rat self-administration studies and the attempted cover-up, which exploded into congressional hearings and really gave leverage to the FDA on many different grounds, a rat study. It provided two bombshells. The findings themselves in studies by behavioral pharmacologist Vic DeNoble, who, by the way, when I left Minnesota, he took my place. So when I was asked to do a congressional report on nicotine research, I just called Vic and said, hey, because he was at Philip Morris, they set up a behavioral farm lab. I said, do you have any data you can share? He didn't, he thought he could share it. And then their attempted cover-up. And as was testified in court, they said, we won't risk $1 billion industry on a rat study that makes nicotine look like heroin. So what did they do? They stopped the research, closed the lab, disappeared the data, and strong-armed a contract with DeNoble and Mealy that they could never breathe a word about this, or they would be severe consequences. So they didn't. And the commissioner had heard about some of this, but they didn't have any evidence. Apparently, nobody knew that DeNoble had shared the drafts of the manuscripts and might have gotten from Steve Higgins. I was a pack rat. When I came to Pinney Associates, the joke was John really wanted my 40,000 reprint file with note cards. But they had actually gotten one of their papers submitted and accepted for publication in Psychopharmacology. And then the hammer came down from management, shut the lab, killed the animals, destroyed the data, never breathe a word about it. So the commissioner, I said, yeah, I've got the papers. And they had a congressional hearing. And that gave FDA considerable leverage. A rat study. The industry got it. Behavioral pharmacology, so as an evidence pillar in the FDA regulations that we worked on during the mid-90s. I was detailed to FDA part-time for that. So Steve, I said, hey, let's do what Steve and I did for the Surgeon General's report, and we had a little paper on it, because behavioral pharmacology is all over the regulation. Just a recent issue. How many of you have heard of a substance called kratom? It's illegal in Vermont and 5 other states. One of the states just flipped over and now has a Consumer Protection Act to regulate it. My understanding is that it's being considered in Vermont because NIDA supports tens of millions of dollars of research, because close to 20 million people are using it to self-manage their opiate use, get off opiates and so forth. But under the name of kratom, a bunch of companies are making something called 7-hydroxy or 7-hydroxymitragynine. There's little 7-hydroxy in kratom, but this actually does, by the same studies that we and others did, that show that kratom's useful, beneficial, shouldn't be scheduled, and has a low abuse potential, 7-hydroxy is. So a week ago, on the 30th of September, the Secretary of Health and FDA Commissioner wanted to see the data from Chris McCurdy's NIDA-funded Florida program. And so Chris and I went down to brief them. That was the day the government closed, so a few hours before. So the deputy led the session, and somebody from the Surgeon General's office saying the Secretary and FDA Commissioner can't be here because the government might be shutting down. They've got to get ready for that. But what were the main data? McCurdy's showing them the basic behavioral pharmacology rat data and comparing 7-hydroxy to mitragynine, which looks more like placebo in most of these studies, and to morphine, which 7-hydroxy looks a lot like morphine in these basic studies, supporting FDA's position. So behavioral economics and tobacco harm reduction. John Hughes, the industry, the pharmaceutical industry, relied on him, trusted him, and also sometimes feared him because he just called it like it was. And I was at a meeting in Europe when his paper with Dorothy looking at nicotine patch, that the initial results, it was effective. 6 months later, significance was lost. So he said, look, by these criteria, it didn't work. He told the people at the meeting that we were consulting to that. And they said, you can't say that. He said, I already did. It's going to come out in the Wall Street Journal and New York Times tomorrow. And I said, John, that's like saying antidepressants don't work if you take people off antidepressants. And he's a psychiatrist. He said, yes, but it's not approved that way. And already at that time, we knew that putting people on nicotine long-term was not a popular idea by anybody except a few companies. But John was, until he died, growing in his passion to say, what do we do for people? Key access is cost as the determinants of access and utilization. VCBH, look at their portfolio. They've been an innovator in all of this. But it was driven by a simple concept: smoke for nicotine and die from the smoke, from Mike Russell. Surgeon General Koop, powerful harm reduction advocate, said the same thing with respect to AIDS, addictive substances, needle exchange. He was way ahead of his time. If you're going to be addicted to nicotine, it's better to be addicted to a form that's less likely to kill you. There's 3 articles that he's done on this. Plan B emergency contraception, which Pinney Associates helped get approved, which is a boon to women's health in America, according to the Food and Drug Administration Commissioner. NIDA Director Nora Volkov said, we don't have FDA medication to treat stimulant use disorders. Even without an FDA-approved drug, there is effective behavioral treatment available, contingency management, but regulatory barriers and unclarity about regulations have limited its reach. We need more treatment centers. And she said the same, that's from her blog, same thing at CPD. Behavioral economics has been one of the most powerful drivers of reducing smoking worldwide. Denis Choinier is here, and I thought, wow, what are you doing here, Denis? But we work together on the World Health Organization Framework Convention, where Article 6 encourages price and tax measures as effective means to reduce the demand for tobacco. A controversial thing that University of Vermont has taken on headstrong, Eric Donnie and Eric Dorothy and others that are here, is what about reducing nicotine, as Benowitz and I said you could do, but you need options for people to turn to in the context of options. And CDC called me and wanted me to come and talk about it. And I called Dorothy and said, hey, you got any new data? And she said, well, I was invited too. And then we found out that Neil Benowitz was. And Dorothy said, well, I guess I got the three musketeers of nicotine reduction and harm reduction. So I made this slide because of Dorothy and presented it at CDC. At that time, it was already so controversial that they backed off and called it a listening session, because some of the tobacco control community was saying, no, you're not going to do harm reduction, you've got to quit. And again, John Hughes stood his ground. He was a pioneer till he died on this. University of Vermont doing this basic research. Really quickly, just wrapping up, lots of areas of behavioral health are under exploration and have been explored. And yesterday, every year for 13 years now, I come to the program, and it is just so amazing. Pregnant women, how to have a healthier pregnancy, cardiovascular disease, weight control, all these areas of health. We've got tools. And contingency management, it hit me yesterday, being used with cocaine and heroin. How many treatments do we have that work on multiple drugs? Most of them are specific to the drug. I mean, naltrexone, you get some benefit for alcohol, but it's mainly for opioids. Contingency management likely works for any drug problem. And given the fact that overdose deaths is a constantly changing pattern, and look at the J-Lal et al. 2018 Science article for really sobering. If you haven't read it, I'll send it to you. It is very sobering. Drug addiction overdose deaths over decades keep rising, but the mix keeps changing. Contingency management, I can't overemphasize how we have to better integrate that. And finally, real-world applications. Behavioral pharmacology and behavioral economics is the secret to space flight, getting astronauts up and down safely. And at Joe Brady's, I forget which anniversary, but about 2010, all these people from the NASA program came, and they said our two big challenges in space flight, especially like going to Mars, are radiation and behavior. And Dr. Brady has been our pioneer for decades. So, and he was working on the Mars program when he died. How do you maintain performance, satisfaction, and sanity on long space flights? He figured out with his program at Hopkins, where they put people in these chambers for months, women did a lot better. The model at that time was pilots, you'd get them that were test pilots and fighter pilots. They do really good in high test situations like a sprinter, but would you put a sprinter in a marathon? Probably not. Women did better. And that led to, hey, we got to do psychological profiling. We need people that share and help each other. Brady is amazing. The Institutes for Behavioral Resources that Brady founded has been run by Steve Hirsch for a dozen years. I was on Brady's boat when he said, hey, I think I can get this guy named Steve Hirsch. And Steve has been amazing, but it's applied behavioral pharmacology economics. Now Derek Reed is joining the program. So, and their addiction program is the model for addiction treatment in the state of Maryland. And lastly, behavioral pharmacology and economics goes nationwide, globally, in business, in neuroscience, in how do we study motivation, brain circuitry, pathways, mechanisms. We have rats press levers. It's kind of fun to see some of the literature because a lot of times you can tell they didn't grow up in the field. They're saying, yes, we did the instrumental technique of animals, or we did the Skinner technique. Language just is different in different fields, but it's really fun. The Incentive Research Foundation, when I was just looking at companies, there are good-sized company that informs companies globally, and they study things like, what are the best incentives? How about vouchers? How about trips? How about dinners? Turns out there's differences in Europe and the United States as to what people prefer. The US vouchers are preferred, but they've got to be culturally specific. They've got to be, and again, this is stuff that University of Vermont is doing. And I don't even know, Steve, if you know that they cite your work. Yeah. Again, it gets more respect in business and companies saying, how do we get employees to have healthier lifestyles and have them wear Fitbits and things? And then they get prizes or awards or vouchers or pay raises for healthy behavior and for maintaining occupational performance and innovation, and guess what? Satisfaction in the workplace. And they talk about it. This is neuroscience informed and behavioral economics informed occupational management. Our field gets a lot of respect outside of our field. Okay, finish up. Who would have thought in the Joseph Vincent Brady Behavioral Biology Research Building, within the Behavioral Pharmacology Research Unit, psychedelic research has taken on a life of its own in the form of the Center for Research on Psychedelics and Consciousness Research. Psychedelics and Consciousness. And there's 3 special issues. By disclosure, I can co-edited 2/18/2023, Harriet DeWitt 2018. They're loaded with behavioral pharmacology, exploring psychedelics, and a forthcoming issue that's dedicated to Roland Griffiths. He was a lead editor at Journal of Psychopharmacology, and that issue should be out in November. But behavioral pharmacology is all over it. And so I finish here. Early pioneer in behavioral pharmacology, adapting applied behavioral economics across the board from his earliest studies, and established a professorship, the Roland R. Griffiths Professorship in Psychedelic Research on Secular Spirituality and Well-Being. David Yaden is the inaugural recipient. It was granted about 6 months before Roland's death, which was really cool. Roland had gotten the first neuropsychopharmacology of consciousness professorship. That was transferred to Center Director Fred Barrett about a year after Roland's death. Current areas of research to serve medicine, public health, and humanity in the center. Addiction treatment, who would have thought, using psychedelics to treat cocaine. Matt Johnson's here. He and Roland got the first NIH grant in a half a century to do clinical research on a therapeutic application of psychedelics, the first grant. And Matt can tell you more about that, but it's amazing. For cocaine, heroin, it has an across-the-board effect. It's not a magic bullet, but for people it helps, it's beneficial. Chronic pain, anxiety, depression, post-traumatic stress, I advise the Psychedelic Bipartisan Caucus in the U.S. Congress. We've had 2 meetings this summer. Hopkins was lead presenters at both, including 2 weeks ago with the staff on how do we move this more quickly and do it right, and also work with the Veterans Administration. So in the Congress, they're taking it really serious. They're saying, look, 25 veterans a day committing suicide, 50 plus more nationwide, and these can help. How do we do it right? Behavioral pharmacology related science is key to all of that development. Spirituality, awe, human connection, and well-being, who would have thought? There's controversy. Should you study spirituality? Roland's answer and mine is this is not about spirits. Do we measure pain, depression, drug liking to schedule drugs, subjective constructs? Yeah, if you can measure it and it's dose related and time related, it's measurable and it's important. But who would have thought where behavioral pharmacology would have gone? So I get inspired every year when I come up here because I see it in the literature, I see it in the work, in my drug development work, that every year I see this amazing hotbed. And as Steve said yesterday, well, the man wants a blue suit, show him the blue light. There's interest in this aspect of health. Let's bring our tools to it. Let's see what we can do to help. That's why the Vermont program is flourishing. It is relevant to humanity, science, and public health. So thank you, Vermont, Steve, all the leaders, all of you that collaborate on this, and congratulations on an amazing contribution to humanity.